So antipsychotics are indicated in the treatment of psychotic disorders such as schizophrenia, schizoaffective disorder, mood disorders with psychotic symptoms. Also, they're often used in patients who have medically induced psychosis, like a psychotic delirium, or drug-induced psychosis. They may also be used acutely to control aggressive and violent behaviors. So there's several treatment goals when you're treating with an antipsychotic. You want to target the positive symptoms of psychosis, which are the hallucinations, delusions, disorganization that the patients have. Negative symptoms, which is the apathy, the flattened affect, the social withdrawal, poverty of speech. The neurocognitive deficits, which refer to the difficulty in maintaining attention, memory, judgment, and insight. So obviously our patients really don't have very good judgment and insight a lot of the times, and these are a lot more difficult to treat, but it is something that we try to treat with the antipsychotics. It doesn't work quite as well as treating the positive symptoms. The other thing we're targeting is agitation, anxiety, depressive, suicidal type of symptoms as well. When you're treating agitation, you usually give an injection of an antipsychotic intramuscularly. Sometimes you can also give it IM. It does an immediate calming and sedating effect, usually within 15 to 20 minutes. But for the positive symptoms like the hallucinations and delusions and the thought disorders, it can take a lot longer for these to respond to antipsychotics, maybe even up to 4 to 6 weeks. So how do typical antipsychotics work? This is a diagram showing that the typical antipsychotics really have a potent D2 blockade. It's a lot more potent compared to the atypical antipsychotics. They also block the histamine. As for atypical antipsychotics, they also block they block D2, less potent, and they also block other receptors as well. So you see the serotonin receptor, 5-HT2A, D4, D1, and then they also block the histamine muscarinic and alpha-1 adrenergic on some levels. So these also cause the side effects. So what are the differences between the side effect profiles? And the major ones that you really need to know are that as per the textbook, traditional or typical antipsychotics, they treat the positive symptoms much better than treating the negative symptoms. So they treat the hallucinations, delusions, and things like that pretty well, but they don't treat that flattened affect and that apathy that you see. That they really are not very good at treating those. They do have a lot more EPS, which is extrapyramidal side effects, compared to the atypicals, and they also tend to elevate prolactin a lot more than the atypicals do. And atypical antipsychotics, they're a weaker blocking of D2 compared to the typical ones, which explains why they cause less extrapyramidal side effects on average compared to the typicals. They also are potent HT2A receptor antagonists. They tend to treat both positive and negative symptoms. So remember this, that atypicals treat both positive and negative symptoms a lot better than the traditional antipsychotics. Also, as a general rule, the atypical antipsychotics usually don't cause an elevation in prolactin, but there's one big exception, and that's with risperidone. Risperidone is an atypical antipsychotic that does elevate prolactin. So here's a nice diagram that shows the difference in the side effect profiles of the typicals on the left and the atypicals on the right. You can see on the right they have a lot more of the metabolic syndrome, weight gain, diabetes, dyslipidemia, cardiovascular disease. And with the classic typicals on the left, you see more of the EPS, the tardive dyskinesia, more prolonged QTC, but you'll have less weight gain, diabetes, and dyslipidemia on average. So how do you choose an antipsychotic? You really do this on an individual basis. You look at your patient, you assess the side effect profile, and you go from there. In general, most antipsychotics work about the same, so they have comparable efficacy. So really your main thing is you want to look at the side effect profile and take into consideration what's important to your patient, who your patient is. Usually we like to start with an atypical antipsychotic first, because they have a lower risk of EPS and tardive dyskinesia. If a particular antipsychotics worked really well for a particular patient in the past, or worked really well for a close family member of theirs, that might be a good place to start, because things that work well in immediate family members tend to work better for patients. Then we have clozapine, which is used for refractory psychosis. It's a great medication. It works really well, but it's a medication of last resort because in rare cases it can cause the agranulocytosis, and they have to be monitored very closely with really frequent CBCs. So they're getting their CBCs done every week for several months. And then it can finally be, the length can be increased to every 2 weeks to get the CBC. And then after a year, they can get CBCs once a month. So they need to be really compliant and get their blood drawn if you're going to start someone on clozapine. So in order to start someone on the clozapine, they need to have failed a couple of trials with different antipsychotics. So treating with antipsychotics. Consider the route of administration. We have oral, we have short-acting injections, which are great for acute agitation. We even have long-acting depot injections. These are excellent for patients who've had a long history of noncompliance with repeat hospitalizations. They forget to take their medications, or they don't want to take their medications because they don't have very good insight and judgment. Some examples of this would be haloperidol, decanoate, fluphenazine decanoate, risperidone, Consta injections. These are great because you really only need to see your patient. They need to just make it to 1 appointment a month or 2 appointments a month. You can give them their injection, and you know they're good to go for the rest of the time. Length of treatment. For someone who's had a first break of psychosis, you want to keep them on their medications for as long as possible. Really, they're probably going to need the medication for the rest of their life. Unfortunately, the risk of relapse is so high, and each time they have a relapse, they have more and more social deterioration and worse prognosis. So at a minimum, keep them on their antipsychotic for at least 6 months to a year after their first break. First break patients, they tend to respond a lot better than chronically psychotic patients, and they also respond better to lower doses of antipsychotics. Early treatment's the key. It is associated with a lot better outcomes. So, traditional, typical antipsychotics, they're classified by their potency of blocking of the dopamine receptors. So, you have low potency on one end of the spectrum and high potency antipsychotics on the other end of the spectrum. They have different side effect profiles. The low potency ones, which include chlorpromazine and thioridazine, they have a lower affinity for dopamine receptors and they require higher doses. They also tend to cause more anticholinergic, antihistaminergic side effects than the high potency typical antipsychotics. So you're going to see a lot more sedation, weight gain, orthostatic hypotension, urinary retention, and dry mouth. Keep this in mind. If you have an older person who comes in with prostate problems, they're already having issues with urinary retention, you wouldn't want to put them on a low potency antipsychotic. Also, the elderly with orthostatic hypotension are increasing their risk of falls. So this is why keeping the side effect profile in mind is really important when you're choosing an antipsychotic. Then with the high potency typical antipsychotics, they have a higher affinity for the dopamine receptors. So they require a little less in the way of dose for the same effect. They are a lot more likely to cause the extrapyramidal side effects and neuroleptic malignant syndrome compared to lower potency ones. So even though they cause less anticholinergic and less antihistamine side effects, they are more likely to cause EPS. So some examples of this would be haloperidol, fluphenazine, perfenazine. So what is EPS? There's a bunch of different types of EPS. They're due to the dopamine blockade. You can get Parkinson's-like features, which include mask-like face, cogwheeling rigidity. You'll see that in their arms. You can do a little test for that on physical exam. Pill rolling tremor. You treat this by either lowering the dose of the antipsychotic, switching to maybe an atypical antipsychotic, or adding on an anticholinergic like benztropine, which is also called cogentin. Akathisia, this is a feeling of restlessness, fidgetiness, usually in the legs. The patients describe how they just feel this intense urge to get up and walk around and move, and that makes it feel a little bit better, but it's really, really bothersome to patients. They may even describe it as anxiety, but when you press them, they'll say it's more of like a physical feeling in their body, not a worrying type of anxiety. Treat by lowering the dose, switch to an atypical, or add on benztropine, or sometimes we use beta blockers that help with this as well. Dystonia, which is dystonic reaction, it usually happens pretty quickly after you give someone an antipsychotic. It's a painful, sustained contraction of the muscles of the neck, tongue, eyes. You can even get laryngeal spasm. This would be life-threatening. You treat it with IM diphenhydramine, which is Benadryl, usually 50 milligrams, and that'll take it away. But this is a huge problem if a patient gets this, because it is so painful and so scary for the patients that they may never trust you to take another antipsychotic after this. It's a big problem. Fortunately, it's rare, but it does happen, and it's a lot more likely to happen in young muscular males. So keep this in mind. So just remember, when you're treating EPS, you either lower the antipsychotic, add an anticholinergic, or for dystonic reactions, you can give the antihistamines like Benadryl. Hyperprolactinemia is another side effect of typical antipsychotics. Due to the dopamine blocking, it causes galactorrhea, gynecomastia, impotence, amenorrhea, osteoporosis, and decreased libido. So you can see why this would be a huge problem for patients, and you can see why they might not be compliant with their medications if they start having galactorrhea or impotence and things like this. It's definitely more common with the typical antipsychotics. However, the big exception, like I mentioned earlier, would be risperidone, which is an atypical, and it does raise prolactin. So, what are the anti-HAM effects? These are the side effects that are caused by the actions of the antipsychotics hitting and blocking the histamine receptors, adrenergic and muscarinic receptors. So when they hit the antihistamine receptors, you're going to see sedation and weight gain, which is more common with the low potency typical antipsychotics. When they hit the anti-alpha adrenergic receptors, you're going to see the orthostatic hypotension, the cardiac problems, the sexual dysfunction. And the antimuscarinic or anticholinergic side effects are dry mouth, tachycardia, urinary retention, blurred vision, and constipation. You can also see dermatological problems, skin problems, rashes, photosensitivity. With chlorpromazine, there is this well-known side effect. Luckily, it's rare, but they do get photosensitive, and they may have a blue-gray skin discoloration with it if they go out in the sun. So really problematic with compliance. Just keep that in mind. Seizures. Antipsychotics tend to lower the seizure threshold. Lower potency ones are way worse at this than the high potency ones. Tardive dyskinesia. This is a syndrome of abnormally involuntary movement. So you'll typically see like a oral lip smacking, type of tongue moving, things going on. They're described as choreoathetoid, which means like a writhing type of movements with their mouth and tongue. They tend to come on about 6 months or longer after the patient's been on the antipsychotics. They have a delayed onset. Fortunately, a lot of the cases of tardive dyskinesia, they go away after a couple of weeks, but it could be permanent, and it's a big problem. If it's permanent, there's no way to really treat it. What we do if we see tardive dyskinesia is we can discontinue the antipsychotic, add benzodiazepines, or start an atypical antipsychotic. We would try clozapine. Clozapine actually helps with tardive dyskinesia a little bit. Because tardive dyskinesia is such a big problem when it happens, I mean, luckily it's rare, but when it happens, it's a big problem because it's permanent. Patients need to be monitored at least every 6 months for tardive dyskinesia symptoms. And you need to make sure that your patient's on the lowest effective dose of the antipsychotics. So, neuroleptic malignant syndrome. What is this? Well, fortunately, it's rare. It occurs more often in males, usually within the first 2 weeks of starting treatment with the antipsychotic. However, it can occur at any time, even after months of treatment at a stable dose. It's a medical emergency. It has a huge mortality rate if it's untreated, so you need to pick this up. Usually starts with some mental status changes, progressing to the patient having a really high fever. You'll see elevated CPK with the labs. Onset usually happens over 24 to 72 hours, and it can last 5 to 10 days. So you'll see fever, autonomic instability, leukocytosis, so you'll see the high white blood cell count, tremor, elevated CPK, and rigidity. It's big rigidity, and it's also called, you may see this on your exam, something called lead pipe rigidity. So what do? You obviously stop the antipsychotic immediately. You give supportive care, hydration, cooling, sodium dantrolene, bromocriptine, and amantadine. They say to use these sometimes in the textbook, but reality, they're infrequently used because they have their own side effect profile. So mostly it's just supportive care. Remember, this is not an allergic reaction, so the patient's not prevented from restarting the same antipsychotic at a later time. But you do need to wait at least 2 weeks to restart it.